And welcome to our live stream here at Deuk Spine Institute. I'm Dr. Deuk Majan. This patient presents to us from
Arizona.
Phoenix, I believe, or Arizona. Scottsdale, do we know? Arizona.
Phoenix.
We'll just call it Arizona. And she's here with her lovely significant other, Sean. She's been having back pain for years. It's getting worse recently. How long has she had her back pain for?
23 years.
23 years of back pain. Too lateral. We need to be a bit more medial. And she found the Deuk Spine Institute, decided she wanted us to fix her back. She traveled here, and we discovered prior to her traveling here that she had 3 discs that were looking right in that area that she was having pain. They were looking like they could be causing that pain. So we made the decision to fix these 3. AP, that's the L3-S1, the L4-5, and the L3-4. We'll show them to you in just a moment. So, yeah. Let's take a look at her x-ray. Now, she had surgery before? I don't think she has she?
Not on her back.
Almost looks like a laminectomy was done, but let's show the lateral view. So you can see the needle, and look at the 5-1 disc. It's extremely collapsed. We call it degenerated. It all started with the herniation. It used to look like the one above, the L4-5. Nice and tall, full, but now over the years it's collapsed. It's put some strain on her facet joint. Look at that facet joint there at L5, L4. Yeah, that's 5-1, and then look at the one above. See the gap? So collapsing discs are not good for facets. That's one thing we know. Shot? She reliable?
How are you doing? You okay? She said yes, she's okay.
Perfect. Tell me if you're having any pain, okay?
Having any discomfort or pain right now?
Shot?
No?
She's tough. AP? She's a very interesting lady. She's very calm, peaceful. All right, so there we are at the border of the L3-S1 disc. Yeah. She is thin. She has a pretty posterior spine. I may be able to do, I'm going to have to look at this 5-1 to see if I can get in, because there is a bone spur. Go back to the AP view. You can see on the AP view there's the facet joints are quite large to the side. And show them the facet there. Yeah, right there, you see that? Yeah, but look at the part that's sticking right by the needle. Yes, that's not normal. That's pushing my my needle a little bit lateral. So we're going to have to make sure we can get in here safely. Are you comfy?
Are you comfortable?
Let's go back to a lateral view.
You have to say yes or no, okay? Thank you.
You're doing great. Everything's going fine. I just want to make sure you're okay. All right. So L3-S1 is always the hardest. Shot? That feels pretty good. Any pain? No?
No?
Yes.
Where? In your back?
On the left.
Bottom
All
left.
right. Perfect. That's all we want. Yeah. We know it's going to be a little uncomfortable for just a second here. Just bear with me. Shot? All right. So we're right there. We may not be able to get in into 5-1 until she's a little more asleep. Shot? All right. Do we want to numb the skin?
Yeah.
We're going to place the needles at 3, 4, and 4, 5 as well. I'm going to give you a little numbing medicine. You'll feel a little stick and burn. It's normal.
You want to try this now?
Sure, if you have one. Is it already open?
Yeah.
Yeah, I'll try it. Shot. I like where we are. Or just a little low in the foramen. Shot.
Yeah, please.
Shot. Yeah. Just gonna give it a second to work. I'm gonna try to climb up a little higher. Are you okay? Shot. She doing all right?
Yeah.
Good. Shot. Yeah. So that bone spur keeps forcing me south towards the feet. We'll get it. I'm not worried. Shot. Give me an AP. I think I might try to come from a little more lateral, just so I can get a little more medial around that bump. Blood pressure is good. Shot. 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 AP. It's better, but you see I'm hitting that bone spur right there. I'm going to try to slip around just in front of it. Huh? Shot? Shot? Alright. Starting to get around it. Boy, that is not easy. Shot? Too high. Shot. That's better. Shot. Shot. All right, AP. By the way, this is the hardest one we're going to be doing. The other ones are far easier to do. So I like to start with the most difficult, because that's going to determine, because it's the most difficult to get to, we have the starting point on the skin is what I'm most interested in. Where do I need to start to get in? Because that's going to determine, obviously, the starting point for the other ones. Shot. I am just threading the needle, they call it. It doesn't get any more threading than that. Let's hope this is enough, but definitely the needle is getting displaced where I don't want it to go. It's getting pushed out of place. I'm not happy about that. You comfy?
Feel okay?
Is that yes or no?
Yes.
Shot. Very unusual. Very unusual anatomy here. All right, I think that's the best I'm going to get it. So let's go ahead. We've already infiltrated. We want to make a 7mm incision. Uh-huh. She comfy?
Are you comfortable? Yes.
Maybe I need a longer one for this. Shot? It's close. Let's see. Shot? Yeah, I need a longer one. Shot. Shot. That looks good. Shot. Shot. Doing all right? Good. We're almost done. We're going to put you to sleep soon, okay? And then when you wake up, we'll be done with your surgery. So if you notice what I did with the needle positioning, I started with 5-1. It's always good to start with 5-1. And then I did 4-5, and I went more lateral. And then for 3-4, I started more medial. And there's a reason for that. Shot. We're almost done, okay? I apologize, it's uncomfortable if it is. But I think you're going to be very happy with your results. Shot. I could feel the disc. Let's get a quick AP. Check things out. At 5-1, huh? I think we'll get it. That's the good news. Oh yeah, it looks pretty. That's really good actually. Better than I thought for 5-1. 3-4, no problem. Are you comfy? Now she's had back pain for 23 years, we said?
Yes.
All right. So she doesn't even look 23 years old. Lower back pain, 23 years. Okay, when I asked her, where is your back pain? She pretty much told me it's in here. The butt crack is right there. And she's got 3 discs here. Go ahead. L3-4, L4-5, L5-S1. If we look at her MRI, those 3 discs are damaged. And I believe her pain is coming from those 3 discs. Now looking at her facet joint on the left here that's so abnormal, I'm thinking that facet joint may be a problem too. So we have to see how she does. She didn't have facet pen on exam, right? Nothing documented?
No.
All right.
5-S1 as well?
No, it's not. I don't think so. Maybe when she's more asleep, we'll get in and get it done. It's so much collapse. Are you having any pain?
No.
No? How bad is that on a scale of 1 to 10?
Give us a number.
How high does it go? What's the highest it goes? 10? 10? Is that where you get your pain?
Yes.
Yeah, you can see her back arch up. Is it better now? You can see the tear. Jordan, show us the tear. Huge tear. Show us where it starts on the inside. Yeah, right there. And then it goes to the outside. So that's a full thickness grade 3 to 4 tear. That's where her pain is coming from. She moving her hands? Huh? She better now? Is that better?
Yes.
How bad is that on a scale of 1 to 10?
7.
What's the highest it goes?
To 10.
10. Is that where you get pain?
Yes.
So we got concordant 10 out of 10, 3, 4, 4, 5. We did not test 5-1 because the needle is just in the back of the discs. I'm not going to inject dye into the back of the disc. There's no sense. So we're going to put you to sleep. When you wake up, we'll be done, okay? Your surgery will be over. And that pain will be gone.
Yeah.
Henry, let's show our audience. Let's show our audience why people get back pain from a herniated disc. Okay, welcome back. Now you understand how do these herniated discs cause so much pain. You see, most doctors think back pain is non-specific. It doesn't have a cause and therefore can't be fixed. So they just want to give you pain pills or shots and never fix it. The reality is we know exactly where back pain comes from, but not everybody does. We do at Deuk Spine. And we're the best in the world at diagnosing the source of back pain. There's nobody better. So we know based on a physical exam, the MRI, and some other tests perhaps we need to do where pain comes from. And that way when we go into surgery like this, we actually test the disc, but we already know what's going to happen. It's gonna hurt because we've already identified the pain source. Shot? The pain source is the tear. You guys saw the tear, right? It was a grade 3, grade 4 tear. Shot? Or take that out. Shot? Uh-huh. Yep. Now, why do I use a mallet? People ask, because it's the safest way to administer a little bit of force without risking going too far. I know we have some questions, Henry, so feel free to ask them.
This first question comes from Debbie on YouTube.
Debbie on YouTube.
They asked, will this help me at my L3, L4, L5, and set joints at S1? No surgery before. I do have bulging discs and stenosis and dextroscoliosis.
Yes, Debbie. This surgery plus the Deuk plasma rhizotomy for your facet, which is done with a little cut 3 millimeters, will take away your pain, 99% of it on average. That's our average pain relief. So yes, come see us at Deuk Spine. You know, you can submit your MRI. We do a free review. And I'd be happy to look at your MRI and do a Zoom call with you. You just got to fill out the form, send us your MRI images. All right, is suction on? No? Yes? All right, here we are. So now we are inside the disc that we just tested. And look at that. That is the tear in the annulus right there. And the blue stuff is the herniated disc, little pieces of it. That's what it looks like. Okay? You've all seen pictures of it on YouTube and the web, but this is what a real herniated disc looks like. it doesn't look like the pictures because they're just pictures. And doctors don't know what herniated discs look like. Only endoscopic doctors know what herniated discs look like because we're the ones putting the scopes in the herniated discs. So to see what a herniated disc really looks like inside the body, you're now seeing that. And I'm trying to grab pieces of the herniation out with my grabber. It's called a pituitary rongeur if you have to know the technical name. Very fibrous. This is not normal. This is not normal disc. You could see the tear right there. All right, now the best way to fix these is with a laser. That's why we call it the Deuk laser disc repair. The lighting is too dark. Let's go up on the intensity by 2 clicks. Thank you. So we're trying laser 6, right? I need it on. Tell me when you're ready. Yeah, we got a problem.
Completely all the way. And the panel is at that?
That's the debris shield in the front. So it tells you when the debris shield is what? Not in alignment?
Debris shield. Jordan, open that case over again.
Wait, before you, should we bring the other laser in?
Yeah, yeah. Start, yeah.
One person grab the next the other laser.
Open that. Just a key.
All right, folks, give us a second. While we're checking the laser, please show our audience a video on how the Deuk laser disc repair actually works when the laser works. Okay, welcome back. You can see from our video how the laser cleans the herniation, the blue stuff, and the inflammatory tissue, the red stuff, out of the tear. This is going to allow the tear to heal naturally. Now, while you guys were watching that nice video, we are switching out our laser machine.
The panel is connected? This is it?
This is the only reason, this is number 7.
This is the laser we used last case?
Yeah. We have to try number 5. The next case on the next.
Yeah, don't worry about that right now. Let's get through the day.
Come on, please.
Scope on, verify the laser's operational, please, and let me know when you're ready. All right, for those of you who don't know, that fiber right there, can you see that, Henry?
Yes, we can.
That is from side to side 1 millimeter, 1 millimeter. If there's still a problem, it could be the fiber. So we're inside the tear, and you can see the 1 millimeter fiber. It's a piece of glass, basically, a long piece of glass. I'm ready. You ready? It is working. Oh, man, that guy should have stuck around, you know, to make sure they were working. I guess he has somebody in Florida he trusts to work on it.
He said that when we start talking to him. Yeah, yeah.
Hmm?
I can have him come over.
Yeah, he should have stuck around and just made sure all three were working. That's what I would have done. Spend an extra day, you know?
Yeah, yeah, yeah.
I mean, after all, you gave an opportunity.
Correct.
All right, so for those of you who have never seen this before, the laser fiber, that piece of glass right there, discharges out the end, right there at the end, laser energy. And that energy is at 2100 nanometer wavelength. Okay, if you look at the electromagnetic spectrum of electromagnetic radiation, you will see at 2100 nanometers, it's basically very powerful energy. Radio waves are also a form of electromagnetic radiation, but they don't have as much energy. The amount of energy that electromagnetic radiation carries with it depends on the wavelength of the energy. Okay, and there's a relationship, believe it or not, between the wavelength and the frequency of all electromagnetic radiation. And that is that if you multiply the frequency times the wavelength, you get a constant. So as the wavelength gets smaller, the frequency gets bigger, or vice versa. And most types of electromagnetic radiation, you guys all know about microwaves. There's some inflammation right there. You see it? Inflammatory tissue, the red. Okay?
Yes,
right
we do.
inside the tear. That's what we're here for. That's where her pain's coming from. Deuk Spine Institute was the first in the world to discover that. That is the actual source of back pain in a herniated disc. So you guys are familiar with microwave radiation, radio waves, shortwave radio waves, laser energy, light, visible light. All of these are waves, waveforms of energy, and we call it electromagnetic radiation. That's the general term. And if you look at the spectrum of electromagnetic radiation, it goes from very, very powerful, high energy with very fast, very short wavelengths, to lower energy, like radio waves. If I shot you with radio waves, it wouldn't hurt you. But if I shoot you with laser, of course it's gonna hurt. Because this energy is absorbed by these proteins inside your body. And the proteins take the energy and absorb it, and then the energy shakes the protein bonds, we're called covalent bonds, and it literally shatters them. So the proteins break down into little bits. And right now what we're working on, this stuff here on a molecular level, are proteins. On a biochemical level, they're proteins, right? And these proteins here are extracellular, meaning they're outside of the cells, and they're within the matrix, extracellular matrix of this disc tissue. But they're causing inflammation. And that inflammation is where this patient's pain is coming from. So I'm delivering a form of electromagnetic radiation, it's called laser energy, to those proteins that make up the scar tissue and herniation to get rid of it, clean it out, debride it. And it works quite well. All right, I know we have some questions, so I'll take the questions.
Yes, this next question comes from Marcus on YouTube.
Hello, Marcus, on YouTube.
They ask, can you give your thoughts about lateral recess stenosis? I'm thinking especially if it's behind the pedicle, can you treat this with this surgery?
Yeah, great question, Marcus. So Marcus is bringing up some anatomy stenosis, for everybody, is just a general Latin term. It means narrowing. And stenosis can apply to arteries and veins. It can apply to spaces in the body, right? Like coronary artery stenosis and carotid artery stenosis. Carotid artery stenosis is what's responsible for strokes. Coronary artery stenosis is what's responsible for heart attacks. And spinal stenosis is what's responsible for pinched nerves and pinched spinal cord. So Marcus is talking about narrowing within the spine in a very specific place. He said behind the pedicle. Behind the pedicle, first of all, we divide the spinal canal into different zones. There's central, there's lateral recess, and there's foraminal, and then there's extraforaminal. Now central is the middle of the spinal canal. Almost nothing ever happens there. It's a dead zone. It's like finding water in a desert. You just don't have problems. Stenosis that causes symptoms happens in the lateral recess and the neural foramen. That's where you see 99% of symptomatic stenosis. Now, the lateral recess is the part of the spinal canal not located behind the pedicle, but actually located medial to the pedicle, on the inside of the pedicle, not behind the pedicle, so to speak. And lateral recess stenosis is responsible for about 50% of symptomatic stenosis. This surgery you're watching treats lateral recess stenosis because I can get to the part of the disc that's medial to the pedicle. Now, foraminal stenosis is lateral to lateral recess stenosis. It's further to the side. The foraminal stenosis is the stuff that's really between the pedicles, sort of. So rather than being on the inside of the pedicle below the facet, it's actually between the pedicles, where the disc is between the pedicles. It's called the foramen, neuroforamen. And this surgery will treat foraminal stenosis. As a matter of fact, this surgery can treat central stenosis, lateral recess stenosis, foraminal stenosis, and extraforaminal stenosis. All stenosis can be treated with this surgery. On the other hand, laminectomy only treats central stenosis, only, which is why they don't work, because they're treating the stenosis in the wrong place. Okay? The lamina are literally sitting over the central part of your spinal canal, not the lateral recess. What's over the lateral recess are the facet joints. So you cannot treat lateral recess or foraminal stenosis without removing the facet joints if you're doing a laminectomy, which is why we don't recommend laminectomy. It's a horrible treatment. It's an old treatment. It's a very bad idea. We don't offer laminectomy very much anymore to patients. Only under very rare circumstances does somebody need a laminectomy. This surgery does the job. All right, we're done with this disc. We're going to move on to the next one. The laser is working beautifully, by the way, for this one. Yeah, just make sure you get it right. We're done. Let's see if we can see the nerve. There's the nerve right there. You guys see it? It has a blood vessel on it.
Yes, we do.
Buried in the fat. That's called the dorsal root ganglion. Since we are at L4-5, that would be the left L4 nerve root buried in the fat right there. So that nerve is leaving. Let me get a little bit more of that herniation right there, sitting underneath the nerve. All right, what other questions do we have from the audience?
Yes, we have a couple more questions. This next one comes from Canes25 on YouTube.
Yeah.
They asked, Doc, I was wondering, in a case like this, is there a chance you could okay it, the tube and the laser in into blast that bone spur to open up the pathway to the disc? This may be a dumb question, but I mean to put the tube and the laser in.
By the way, look at the hole in the annulus when I got done. It's now less than 3 millimeters. It's around 2 millimeters. Okay? That's because the laser helps shrink up the hole. It's 2 millimeters. It was about 5 millimeters. Remember that x-ray that we took where they had the dye in there? That was a huge hole. That was about probably even closer to 8 millimeters or a centimeter wide. Now it's 2. So the laser helps shrink up the annular tear. Okay, and then Keynes 25 asked a question, but I'm not entirely sure what Keynes 25 is asking. Something about bone spurs and lasers.
Yeah, in a case like this, is there a chance you could you could put the tube and the laser in to blast that bone spur to open up the pathway to the disc?
Oh, the facet bone spur. He's talking about the enlarged facet joint. Yes, there is a way, but you have to start out in the disc. I won't start out with the facet joint. I don't do that. And we're probably going to be able to get into the disc, Keynes 25. I'll show you what I'm going to do to get in there. So I'm not that worried about getting in. I just couldn't get in the beginning. And by blasting the facet and removing part of that facet joint, remember that extra bone on the facet joint's there because the body is trying to stabilize that segment of the spine. It's responding to stress. And if you start removing bone out of the spine, you're only going to weaken the spine more. So I don't like taking any bone out of the spine. Shot? All right, I'm going to do number 3-4 disc, which was a 10 out of 10 pain. Shot? Uh-huh. We're going to do number 3-4. Hold this here. Hold this here, yeah. Hold on. Shot? Yeah. Okie dokie. Keep the questions coming.
This next one comes from Tony on YouTube. And they ask, will this procedure have a lifespan before fusion is needed or full disc replacement?
Hey, Tony, thanks for asking. People that have this surgery don't need fusion or disc replacement. This surgery replaces fusion and disc replacement. Shot? We've been doing it 17 years. And the people who got it done 17 years ago, 16 years ago, they don't come back. They're done. One and done. And it makes sense, too, by the way. If you understand the pathophysiology of back pain from the disc shot, you understand that what we're treating is not something that needs a fusion. The fusion is a very bad way of treating this problem. And fusions are promoted by 99% of spine surgeons. That's why people talk about fusions. If the spine surgeons knew how to do this surgery, which is far too advanced for them, then they wouldn't be recommending fusions to you. The other thing is fusions do pay surgeons a lot more than these types of surgeries. So who recommends surgery? The hospital doesn't recommend surgery. The surgeon recommends surgery. And surgeons are who meet you in the office, right? So if a surgeon is meeting you in the office recommending a treatment, are they going to recommend the treatment that is best for you, that pays them almost nothing, or a surgery that pays them more money? The problem is surgeon shot. That's it? All right. You know what to do here? Let me see. Yeah, you got to hold it against the wire. There you go. The problem is surgeons are unfortunately making recommendations to their patients based on their reimbursement rather than what's best for the patient. Shot? Fusion is never better, ever, than this procedure. This procedure will replace all the fusions eventually, except for the ones done for fracture dislocations, tumors, and infections of the spine that cause the spine to fall apart. In those cases, fusion will still be necessary. But fusion for degenerative disease will no longer be necessary or performed by surgeons. All right. We're inside the annular tear at L3-4. Let's not let this come out. All right, when we remove it. No. I just want to be careful. Keep the questions coming, Han.
This next question comes from MS on YouTube.
Again, this cable, you guys got to keep the cable away from my feet. Come on over here. Move the cable away. Okay. Thanks. Go ahead.
This question from MS on YouTube asking, what circumstances would you warrant doing that surgery where you are laying on your side and they go through the psoas muscle? I saw another surgeon on YouTube doing that procedure. I'm sending my MRI to you, and I've watched and have for some time all of your videos.
Oh, thank you. So what you're talking about, my friend, is something called the trans-psoas approach to the spine. And, you know, when I answer your guys' questions out here, I don't beat around the bush very much, and I think most people appreciate that. The trans-psoas approach was developed by a spine surgeon who's out of South America. His name is Luis Pimento. Luis Pimento. I can't remember if it's a P-I-M-E-N-T-A or P-I-M-E-N-T-O. Anyway, he developed the trans-psoas approach. He developed the trans-psoas approach after the ALIF approach, which is a transabdominal, and the transabdominal retroperitoneal approach through the front were already developed, and also the posterior approach, which is called the TLIF or PLIF. So he did it because he thought, you know what? So many surgeons, orthopedic surgeons in particular, if they go through the belly straight on, they get all these complications. Like patients will have their blood vessels cut, they'll lose their leg during the surgery, their leg will go cold and pulseless, and the doctor will have to cut the leg off. And they perforate the bowels, you know, they cut through the intestines, and then there's poo everywhere, and patients sick and dying. So there were all these complications. The ureter was getting cut, kidneys were being damaged, bladder was being damaged. So many complications through the ALIF. That's why the back surgery through the back was developed, the PLIF, and it was safer and better, but orthopedic surgeons are very scared to do it because you got to work around the nerves, and the orthopedic surgeons just cut the nerves all the time. So they were causing all these complications. So then Luis Pimento said, you know what? What if we go through the side? Then it's not an anterior approach, so we don't get all the horrible complications with the chitlins and the ureters and all that stuff, but we're coming from the side, so there's less chance of complication. And he developed that trans-psoas approach. This was back in early 2000s. I don't remember the exact date, but the trans-psoas approach became popular around 2000, let's just say, maybe 2003. And of course I was trained on it, and I met Dr. Pimenta. But the truth is that if you're a really good spine surgeon, you don't want to do trans-psoas, because patients with trans-psoas, they have these horrible complications. Now, the complications are not as bad as a transabdominal and ALIF approach, ALIF approach, but they're still pretty bad. Like if an ALIF has a 50% complication rate, then a trans-psoas approach has maybe a 25-30% complication rate. Now the problem with the trans-psoas approach is that the nerves from the lumbosacral plexus run through that muscle, and the surgeons are always damaging those nerves. And the patients that have that surgery, they can't lift their leg, their thigh. They have trouble lifting their thigh because of the surgery. And for many people it's permanent, because the surgeon permanently damages the nerves, not on purpose, but just because the nerves are hidden in the muscle, the psoas muscle. Yeah, it's very painful. So long story short, if you're an amazing spine surgeon that can do everything, you're going to do, if you're doing fusion, you're going to do a T-lift. That's what I did for many years. You know, I was trained with the best, and I was literally one of the best fusion surgeons in the country, in the world. And I stopped doing them pretty much. But I was doing T-lifts, and all my patients go home without deficits, without complications, 2 hours after the fusion. And it doesn't matter if I'm doing 1 disc, 2 discs, 3 discs, 4 discs, or even 5. My patients would go home 2 to 3 hours walking, dancing. If you go to our videos, you can see our dancing fusion patients. And those are 10 years old, those videos, because I was doing that in 2013, 2014. My point is, the trans-psoas approach is better than an A-lift, but worse than a T-lift. If you know how you're doing, if you know what you're doing, and you can do everything like I can. So here's where it becomes important. Folks, let's pretend for a moment you're in, I don't know, Seattle, Washington, and your surgeon is in Seattle. And your surgeon knows how to do 2 types of fusion. They can do an A-lift or they can do a trans-psoas, X-lift they call it, okay? Now your surgeon, let's call him Dr. Lateral. Dr. Lateral has a complication rate of 50% with A-lift. And he has a complication rate of 90% with T-lift, TLIF, the best surgery. Okay, 90% with T-lift, 50% with A-lift. So he's really bad at T-lifts. He's, average for A-lift. And then with the X-lift, the lateral trans-psoas approach, his complication rate is 30%. So which surgery do you want him to do? Which surgery do you think he wants to do? He can either go A-lift, X-lift, or T-lift. T-lift, 90% of the patients get a complication. A-lift, 50%, and X-lift, 30%. That's how surgeons really typically should evaluate the treatment recommendation. Now, the best surgeons would say, you know what, go see Dr. Deuk Majan in Florida because he does better surgery than anyone I know with the laser. That's really what they should do. But they're not going to do that because they're going to go out of business. They didn't go through all that medical school and training to go out of business. So they're going to offer you their best option. Now, if they're being paid off to, put screws and rods in, they may actually recommend a different kind of surgery, right, that they're getting paid off for. But if they're not getting paid off, they're going to recommend the surgery that's best for them, not best for you, okay? I guess it's best for you, the patient, because the complication rate in their hands is the lowest. So when surgeons go to meetings and talk, we talk about what's the best surgery to do for a patient, and we put up MRIs and X-rays and talk about it. And the caveat is always, in my hands, the surgeons say, in my hands, I would do a T-lift. In my hands, I would do an A-lift. In my hands, I would do a X-lift. What they're really saying is, because I suck at the other surgeries, this is what I would do. And, it's all fine and everything to talk about that at meetings, but the reality is patients are suffering as a result of their surgeon's incompetence. And in my opinion, you should either get really good at doing spine surgery or stop doing spine surgery. I'm not really good at brain surgery, so I stopped doing brain surgery. Okay? It's just about knowing what you're good at and being honest with your patients and yourself. The problem is these surgeons that do trans-psoas approach, they're not very good spine surgeons in my opinion. Now, of course, they would probably cut my head off if they could for me saying that, but that's my opinion, and I'm entitled to my opinion, okay? Some people might not like it, but that's my opinion. Okay, we're almost done. Just about finished here. Look at that inflammation right there. Gonna clean it out. We're right against the end plate. Everything is going really well for her so far. We've got 1 more disc to do, the L3-S1. Any questions?
Yes, we have a question from MyTai11 on YouTube.
My Thai 11, I love it.
And they said, "Hi doctor, if you haven't already addressed it, how do you remove all the scar tissue and disc material with your laser technique without hurting the nerve that is being affected by the rupture or I just had ACDF 48 hours ago with a lot of bone spurs and a 50% occlusion of the nerve foramen aviator system, C6, C7.
Wonderful. Well, Mai Tai 11, don't have any Mai Tais at 11 today. You need to heal up first, okay? But if you had my surgery, the Deuk laser disc repair, and you were 48 hours post-op, you'd be enjoying a couple of Mai Tais right now because you would not be on any narcotic painkillers. We don't use narcotics on our patients. They don't need it. There's no pain. But to answer your question, we are not removing the disc. A lot of people don't understand that. We're not removing the disc. We are cleaning the tear where the herniation is. It's called the annular tear. And it's the outer 1.5 centimeters or 15 millimeters. Now you see the inside of this tube right here that I'm using the laser on? That's literally 5.5 millimeters. So the annular tear is 1.5 centimeters. That's 3 times that width, going down deep into that hole right there, down there. Okay, so I clean out the tear. I'm not taking the disc out. Now, as far as scar tissue goes, I'm not taking all the scar tissue out. I'm only removing the scar tissue that's causing problems for the patient. So I can see where that scar tissue is, and I'm using the laser to remove it right here. See that? As a matter of fact, that's scar tissue right there at the tip of the laser, that white stuff. And you see the orange stuff? That's calcium. Calcium inside the scar tissue. This is all scar tissue right here. Now, I'm removing it because I'm looking for the herniation, and I want to get rid of the inflammatory tissue that's causing her back pain. But otherwise, I don't take scar tissue out. There's no need to, unless it's causing problems. But I hope you recover quickly from your surgery. I really do. And I'm happy. Hopefully you're doing well. But if you need your back fixed, do not go get a fusion. Come to Florida. Come to the Deuk Spine Institute. You get the best treatment in the world right here. All right, so let's take a look at the nerve again, because we're just about done. This is the outside of the disc, the end of the annular tear, and I'm going to be able to see the nerve root. The nerve I'm talking about is the nerve root. Now, all this stuff was pushing on her nerve. This is all scar tissue and herniation right here. Remember, that's a 1 millimeter laser fiber, 1 millimeter wide. That gives you a reference point for how big everything is down here. It's very small. We're in a small little spot. Huh? Is she a little, oh yeah, for the last one? I think you're okay. So there's another nerve up there, right up there in that vein where the vein is. But there's a little bit of herniation still here, so I'm going to finish cleaning that up. But so far it looks good. There's the hole that where herniation came out of, and the herniation is gone. There's some veins right there, kind of cool. And you can see those. I'm just trying to finish up cleaning all this stuff up. Any more questions?
We have a question from Premier Media Group on YouTube.
Yeah, sure.
They asked Dr. Deuk if Luis and Dr. Demola found evidence consistent with bilateral leg nerve damage during a NCS and EMG, will this potentially improve over time post-DLDR?
Yes, that's correct. The nerve damage you're talking about is called radiculopathy. And it comes from pressure on the nerve root being pinched by the herniation. After the Deuk laser disc repair, we're getting the pressure off those roots. They will heal. Will they make 100% heal? Hard to say, but I would say pretty darn close if you had the Deuk laser disc repair. This is all scar tissue. Look at that, just solid like a rock, full of calcium. I just want to make sure, because the nerve root does swing around past this, and it's going to go right over the top of that thing, just on the other side of the dilator. I mean the tube. So I want to make sure I've debulked it enough. I've got enough of the mass out of there. Still a little bit of herniation there, not much. But if I can get this thing debulked enough, then the nerve will not be pressurized anymore. By the way, this is extraforaminal. Right there is extraforaminal, right? That's the extraforaminal part of the herniation right there. And I'm just trying to shave it down with the laser. It's working very nicely. But this is part of what I do for people. So I can get lateral recess, I can get foramen, and I can get extraforaminal. All right, we're done here. We're going to do a little antiseptic, some betadine. We have one more surgery today. Our last patient is 2. She's a 2 level, right?
Yeah. It's paratrauma level, yeah. 2 level.
4?
No.
Oh, right. Oh, okay. Yep. I'm not complaining. Any more questions? So far, she's doing really, really well. I'm very pleased with our results. I got to be honest, the discs are a lot worse looking inside the disc than they were on the MRI. The MRI just showed some abnormalities, but I got to tell you, being inside those discs, tons of scar tissue, tons of calcification called dystrophic calcification, and a lot of mass effect on the nerve. So it's no wonder why this poor woman's been suffering. 23 years of inflammation. Creates a lot of scar tissue with 23 years of inflammation. You comfy? Shoot, I'm sorry to hear that. All right. Well, here we go for our last level.
We have a couple more questions.
Sure, I'll take the question.
This next one comes from Mara on YouTube.
Look at that little piece of herniation right there. You guys see that? Not a big one, but we got lots of these little pieces everywhere just sitting around.
Yeah,
Remember, we bust up the herniation, we float out the pieces, and they kind of just fall everywhere over here in the operative field. Yes, Mara.
Mara asks, can I get this surgery in the UK?
Well, if you invite me and my entire team to the UK, yes, but it's going to cost you a lot of money. I would strongly recommend you come to Florida and get it done here rather than fly us to the UK. The reality is it's not available in the UK. I know that the London Spine Clinic is basically trying to make people think they do my surgery, but they don't. And the people that have gone there, they eventually end up coming here, many of them, because their procedure over there doesn't work.
Not a bad idea if you take this show on the road on tour.
Go on tour. Like, what's her name? Taylor Swift? Right? No, it's not available in the UK. I'm sorry. But we do have a lot of people from the UK fly here. So if you can make your way here, shot? Is that it right there?
That's correct.
All right. This is going to be the hard one. Shot? All right. I'm not happy about this one. Shot. Getting past that huge bone spur right here. I feel it. It's squeezing down on my dilator. Yeah. Oh, yeah. Shot. All right. Hold on. I gotta. It's not gonna be easy. Shot. Man. Let's get an AP. Let's see where we are. Shot. Hold on. Shot. All right. Well, let's go back to a lateral. Let's hope. L3-S1 is the hardest to do. No, I don't like that. It's pushed me too far lateral. That's the problem. Shot. No, I don't like that. I feel the bone. Shot. No. It's very strange. Lateral. Give me an AP again.
Try me to move the needle in the guide wires.
Let me just see where we are here. Shot. I don't know if we're rotated. We may be rotated a little bit. We're definitely lateral here. There's no doubt about it. We're definitely lateral. Shot. See, that looks better to me right there. But then when you look at the lateral view, let's go back to a lateral view. I'm not ready for that. See, we're not in the right position. That's the problem. And it looks like, I mean, if that spine's not rotated, shot, just doesn't make sense. I can't do that. You don't think it's off on orbit, do you? Let's try some orbital maneuvers. Shot. That almost looks better, but it's still too lateral. Too lateral. Yeah, I feel the bone there. It's blocking me. It just won't let me go more medial.
It's kind of skiving off of that.
It's skiving. Let's see if we can wag it a little bit. I think we're off just a tiny bit on wag. I think we're still off on orbit. I think we're off on orbit. Shot. I think that's still bad. Try some more. Shot. What do you think, Jordan? Worse? Yeah? Looks worse. Try the other way. Shot. See, that looks really good from a lateral perspective. Maybe a little more. Maybe she's rotated the other way. That looks even better. Oh, let's try going a little bit more. Shot. I think that's worse, right? Or what do you think? What do you think? Try? I don't know. I almost feel like it is better. It's weird. Let's go back the other way again. That's same way you were going before. Not earlier, but just now. Bring that side up. Isn't it your side up or not? Now it's worse. Go the other way. Shot. We're actually almost there. Shot. I think that's as good as we're going to get it.
That's back to,
Huh?
that's back to flat 90 degrees.
Yeah, I think that's the best we're going to get it. And I mean, it doesn't look too bad to me right now. Shot. It's just every time I push in, it's going lateral. That's the problem. I'm going to try to aim more medial. Let's see if we can't get it. Shot. Shot. I mean, to me, that may be the best we can do right there. Oh yeah, shot. That's inside her disc. Man, that is bad. That is really collapsed. Let's take a look. Might be able to get some of that inflammatory tissue out of there. Since we're here, let's take a look. Shot? Oh, we're there, huh? We're there. Shot? Is that us right there? Yeah. Shot? All right, let's take a look. It's the best we can do, given her abnormal facet situation. Be just real gentle. Yeah, the nice thing about the system is it's designed not to harm the patient's body because of the very blunt tip of the dilator. And then the tube just slides down. Yeah.
We have a couple more questions.
That may be the lateral part of the disc right there. Hold on, no, I can't use the grabber. No questions right now. Let me just focus.
Copy that.
And I can take the questions when I'm done. Let me just focus here. Well, somebody wanted to see an extra foraminal approach. And this is it. And that's why we don't do it. Not much in there. But yeah, that is just, that's the herniation. It's just so thin because the disc is so collapsed. You can see it is pretty inflamed on the outside, all the red. I got a minute at most. I feel this stuff melting. So hopefully this does the trick. It's inside the disc, that's for sure. We're just about done, guys. I don't want to do any harm to her. All right, that's probably as good as I'm going to get it.
Sitting down, please. Drop off. Thank you.
So that 5-1 is so collapsed, and more importantly, it's not the collapsing that's the problem, it's actually the facet, abnormal facet joint, pushing my tube away from the disc to the side. Really abnormal, but we'll see. I felt pretty good about the whole surgery. We did get 10 out of 10 pain on the 2 discs we tested, so I know she's going to be a lot better. I still expect her to be at 100% from these 3 discs. Thing about it is the more arthritic and collapsed one of those discs are, the less movement they have. And we were able to get that laser in there and clean out some of the herniation and debride the tear. Okay, all done. Great job, everyone. We have one more, folks. Did I? No?
What is it?
I didn't do.
you inject.
No, I did. So the last surgery will be a lady with 2 discs that need to be repaired, and we're going on both sides, right? You can break the scope down. Break the scope down. I'll do. Scope.
Rocket turnover on the next.
Yeah, scope use was a, I would say a 6. Yeah, it went well. You guys see her incision is tiny. I'm trying to get her tape off. There we go. The whole thing was done with 1 incision. So that's nice. Very little bleeding. We'll get her staples out tomorrow. Before we send her home back to Phoenix. I think Phoenix, somewhere in Arizona. Great job, everybody. Henry, let's go to one of our testimonials. I'll come over there and answer some questions.
I'm here with a patient of mine who traveled all the way from South Carolina to come to the Deuk Spine Institute. She's a healthcare provider herself. She's had some back issues. She had the Deuk laser disc repair yesterday, and she wants to share some of her experience with you. Tell us about your back pain and your leg pain before your surgery yesterday.
I had surgery on L4, L5, L3-S1. So my symptoms were classic. I had the sciatic pain that ran down my leg. Every once in a while my foot would go numb if it was pretty irritated. And then I had pain along the top side of my hip. So pretty normal type stuff. I was going to the chiropractor, I was getting massage therapy, I was starting on meds once I did imaging and made sure that this was actually a herniation and not just like a muscle pull or something. So I had kind of gone through all the things. Had back surgery in 2020 at another institute, and they did a microdiscectomy / laminectomy of L4, L5. I was good for maybe 2 years, almost 2.5. Before it re-herniated. So not the most fun in the world, because you expect whenever you go to have a procedure that it's fixed and your life will be ongoingly better. But I'm a nurse and I ride horses, so I'm pretty mobile all the time, and that kind of pain just really gets you down.
So why did you travel from South Carolina to Deuk Spine? What do we offer here that you couldn't find there?
I was on an internet, the great internet search, to find out more information. So to read more about spine surgeries, about how many times people relapse, like all what's involved. I surely didn't want to go up to a fusion because that's absolutely ridiculous. So I happened to find one of your videos on YouTube. You offered the laser therapy. I was just sold like almost as soon as I saw it, because it made sense to me.
Yeah, having the perspective of being a nurse and a healthcare provider, it makes sense. You're fixing the problem, debriding the disc tear, allowing it to heal naturally into a pain-free state. You had your surgery just yesterday.
Just yesterday.
Not even 24 hours ago. Were you in the hospital for your surgery? I
I was here in your surgery site. I got here around 1 o'clock-ish. Did all my pre-op stuff, rolled in probably around 1:35. I think our procedure lasted not quite an hour. I was out and eating dinner with my dad at 5 o'clock at a restaurant that your anesthesiologist recommended.
Oh, good.
Dr. B, he's great.
So no hospitalization.
No.
No morphine pump after surgery because you're in so much pain from
Not
the
at all.
surgery. No narcotic painkillers after surgery, right?
No.
What did you take for pain that we gave you? What new medicine did you take after surgery?
So I haven't taken any new medicine after surgery. I was on Robaxin and gabapentin prior to. Of course, I have to wean off gabapentin, so I did take my gabapentin this morning, but I didn't wake up in any pain. But unfortunately, that med you have to wean off of, so it's not like I can stop it to cold turkey.
Yeah, so basically we did a small incision. We went in with the laser and debrided your tear. And at the end, we had a tiny 7-8 millimeter incision. And there's really no pain after the surgery, so there's no need for narcotics. After your prior microdiscectomy, you probably needed to take some Percocets
that
or
was,
oxycodone.
just to roll out of bed, just to get up off the couch after that
hurt.
surgery.
It's painful.
It's painful.
Yeah.
It's absolutely painful.
And the difference, people ask me, what's the difference between Deuk laser disc repair and a microdiscectomy? The difference is a microdiscectomy goes straight into your spine. The surgeon has to pull all the muscles off your spine. Then they have to drill a hole in the bone to get to the disc. And they have to remove ligaments, and they have to take your facet joint partially out. There's so much destruction that goes on under the skin. The surgeons don't talk to the patients about it because
No, they didn't.
everybody does it. They think there's no better way, but there is a better way. It was developed by an Iranian orthopedic surgeon to come from the side. And I'm a student of one of his students, so second generation endoscopic surgeon, transforaminal. And it's a better surgery because it doesn't cause any damage to your spine or your body. It's wonderful.
It is wonderful, I'd have to say.
And how do you feel today? Is your preoperative pain gone?
Oh yes, all of that's gone. The only thing that I feel is like right in mid-spine where you basically stab me. And that's,
Yeah, you know about
That's-
that. You watched the videos. So,
brought
yeah.
a tear to my eye there for 1 little second.
I see.
I forgive you.
Thank you. Thank you. Well, I'm glad you're doing well. Is there anything you want to say to your fans and friends out there? Because we know you have friends. I did some shout outs.
Oh yeah, you did do some shout outs to my nurse friends, which I appreciate. And my husband has just been wonderful through all of this. He just wants me pain-free and I love him for it. So
That's
he
awesome.
was a major contributor.
What's
even
his
though
name?
Ted, even though he's not here with me,
Hi,
he's
Ted.
here
Thanks
in
for being so
spirit.
supportive. Yeah, you're lucky you have a supportive family. you know.
Absolutely.
It's hard for people to do this alone.
Yeah.
right?
Yeah, my dad drove me down, so he's been here with me because he can, he's retired, so he can come down. And then my husband, we have a farm, so he stayed to take care of the animals.
Well, congratulations.
Thank you so much. I
Safe
appreciate
travels.
you.
You're welcome.
Yeah.
All right. And good morning, I'm Dr. Deuk Magin here at the Deuk Spine Institute with a patient who's traveled 10 minutes from Merritt Island. Is that correct?
I'm in Vieira.
Oh, Vieira, just down the street. Okay, local. You just had the Deuk laser disc repair on your lower back yesterday for a herniated disc at L4-5. It was a foraminal herniation, and it's one that is tough for doctors to find and discover. But we saw it at Deuk Spine, and you were having horrible back and right leg pain. That was yesterday before your surgery. Here you are less than 24 hours later. How do you feel?
Wonderful. Walking straight. I feel no leg pain, no back pain. Just a little sore, but that's about it.
How long have you had the back and leg pain for?
Since 2012, 2013, since my surgeries.
When you live with pain,
Right.
he had, I guess, a microdiscectomy done.
Correct.
Did that fix him?
No, a month later he was back in surgery.
What kind of surgery did you have done?
The fusion, S1, L5.
So you had an L5-S1 fusion, good. Did that fix your problem?
No,
No.
not at all.
And their suggestion was take the metal out, and that they already seen that he had a problem with the disc above that one, so let's take the metal out first, then within a year go back and do another fusion on the disc above that.
And that was the metal they put in you.
Yes, sir.
So they put metal in you for the fusion, and then they told you afterwards, well, we got to get it out because that's what's causing your pain.
Right.
Kind of silly, isn't it?
Yes, sir.
All right, glad I'm not the only one that thinks that's a bit silly, but that's right, it is silly. And it's not just the surgery, the fusion. Didn't you have pain management and stuff in between?
Yeah, so I had shots and a nerve specialist do some stretchings and hands-on stuff, but that's about it.
So you had shots, you had therapy, and then you had surgery, and you had more shots and therapy. And that's the problem is you're like I think about it as like a washing machine
Yeah.
going around and around, and they're just washing the money out of your pockets and washing your life away because your quality of life has not been good, has it?
No, not at all.
How did you find Deuk Spine Institute?
My wife.
I couldn't believe it, amazing. Last time he had surgery, 9 days, he couldn't even hardly move.
Mm-hmm.
And I mean, he was up last night pacing the floors, antsy, trying to find something to do.
This must cost your family a lot of money dealing with the pain over all
Oh
these
yeah,
years.
well, and it cost him not just with the pain. He's not able to do the stuff he likes, fishing, throwing the baseball with our son. So just just doing life things is not.
Wow, what a surgery, huh? Well, it stands to be true that no two surgeries are the same, are they? So many variables. And in this patient, we confirmed indeed that her two discs, 3, 4, 4, 5, were indeed causing the 10 out of 10 pain. She probably won't remember the discogram because we basically don't want patients remembering any of the bad parts of the surgery, like the pain or even the experience. So we give our patients something called Versed, V-E-R-S-E-D. Versed is an amazing drug. It basically doesn't let you make memories, and just for a short period of time. It's not permanent, it's just temporary for a short period, about 15-20 minutes, and that way patients don't remember the anesthesia. It's pretty standard to do. So good anesthesia is going to have the patient not remembering, not feeling pain, not having pain, and basically sleeping comfortably through the surgery, which she did. She did a great job. Couldn't have gone better for her. The only issue we had was the facet joint at L5-S1. And the facet joints are little joints in the back of the spine, very important part of movement. You can see this one moving here. But if you damage your facet joint, over time, usually over 10, 15 years, it just gets bigger and bigger and bigger. It grows. The bone grows. The joint grows. I've seen facet joints 5 times normal size. 5. Literally 5 times bigger than they're supposed to be when I've done surgery on people. And in her case, that one was about 4 times bigger than it should be. So the window I have of getting into her 5-1 disc is like this. Can you guys see this here?
Yeah.
All right. So if the facet joint is too big, it pushes my tool laterally here. I call it lateral to the side, and then you miss the disc. So we were able to finally get in there. When I really went like this, I pulled the tool to the side and I really aimed and pushed against the facet, and I was able to get in and get some stuff done at 5-1. The other two discs were relatively easy to do. I didn't have any issues. That said, this one was challenging. So, what questions can I answer for you all?
This first question comes from Guy on YouTube.
Gotti.
Guy asked.
Guy or Gotti?
Guy.
Guy.
Yeah. Guy asked, "Hi doctor, how do you treat a burst fracture at the T10 affecting surrounding disc? I sent my MRI but never got a call."
I'm sorry to hear that. Well, if you sent your MRI, you wouldn't get a call, just so you know. You have to fill out our form. We have an online form, the MRI review form. You'd have to fill that out completely and then send the MRI by mail. And it'd have to be sent by FedEx or UPS, not email. Those files are too big to go by email. So if you had done the form plus the actual MRI by mail, the next thing you can do is call Sam. She's at 321-775-1299. She's in charge of the MRI review. Sam, be nice to her, and she will make sure you get your MRI review done. So what do you do for a burst fracture? There's really, it all depends, okay, on many factors. But one of them is, how old is the burst fracture? Okay, is it recent or is it old? If it's recent, like within a few days, maybe a week, it should be operated on pretty quickly. On the other hand, if it's old, then you may not need to do anything with the burst fracture. It may be healed. And you may just need to fix the discs above and below. So I would need to know how old the burst fracture is. I would want to see the burst fracture with a CAT scan. I'd want to analyze the fragment distribution and the split of the fracture. Is it a coronal or sagittal split burst? And how far apart are the fragments? Is it unstable? I'd want flexion extension x-ray. I want to see if it moves. But if you had a new burst fracture, I would consider two options. If you're neurologically intact, meaning there's no nerve damage or spinal cord damage, I would do either what are called pedicle screws, where you go in and put pedicle screws and rods that stabilize the segment, take the most of the weight off the burst fracture so that it doesn't crumble down and crush down and burst out more, and it would allow the burst fracture to heal. If you're young and healthy, you got good bone metabolism, your burst fracture can heal. If you're neurologically intact, you just go in and put the screws and rods. You can take them out a year later and the burst fracture will be solidly healed. But this way you prevent the formation of a kyphotic deformity where your spine shifts forward and crushes down the fracture more. The other option is to just do a fusion. And you want to do 2 levels above the fracture and 2 levels below. So there would be 2 bones above the fractured bone and then 2 bones below. That's typically what I would do. Some other doctors would do 1 bone above and 1 bone below, but it depends on your bone quality, how old you are, how bad the fracture is it displaced, is there neurological compromise. So there's a lot of factors that go into that kind of decision about treating traumatic burst fractures. It's not a simple treatment, but I'm happy to look at your MRI and if you have a CAT scan and try to advise you.
This next questions come from Maitai 11, once more on YouTube, and they asked how you not injure the nerve with that laser. Follow up about your process. Is a CT scan sufficient for you to operate on a patient? I'm a retired fire captain with cervical arthritic/disc troubles, likely due to helmet use over 32 years. Reason why I'm asking is because I cannot have MRI in some circumstances due to DRG stimulant implant.
Yeah, so fire captain, number 1, Mai Tai. First of all, I think you said you just had ACDF fusion done 48 hours ago. So I would be interested to know where you're having problems. Is it your lower back? If so, a CAT scan could be very helpful. I would definitely start with that. I would want to do an examination, see where is your pain. Typically I can figure out where pain's coming from by just examining you, looking at your back, and then I confirm it with studies. So my advice is fill out one of our forms and we'll be happy to do that. How do we protect the nerves? Here's how we protect the nerves. This is a nerve right there, right? You guys see that?
Yes.
How do I protect the nerve? I come here, I go under the nerve, and I go into your herniation, and I use the laser to zap it out. The nerve is protected because it's outside the tube. That's how. All right, next question.
Next question. I believe that is it. That is it.
Wonderful.
One person, George, asked from YouTube, what do you inject at the end?
What do I inject at the end? So what I'm injecting is, whenever we do surgery, we like to clean everything out with, it's called irrigation. And typically we'll have antibiotics in that irrigation so that it prevents an infection. So we're using betadine and water, and that's pretty much what we're doing to clean things out. So it's really just irrigation to get rid of any debris that we missed.
That is it for questions.
Have a wonderful afternoon. We'll be back in 30 minutes with our last surgery. This lady comes from Canada, and she has L3-S1 herniations on both sides. And we're going to go on both sides.